Thank you, everyone, for joining us. I'm going to begin. We'll be expecting a number of people to join during the first part of this presentation. But welcome, all of you. We're very excited to, with our colleagues now consulting, to provide a seminar on building effective case mix funding models and get some insights from Australia. We've done a series of webinars and events, and I'll certainly circulate those after the event. We did a breakfast policy forum on activity-based funding early in the year. We plan to do some ongoing webinars of topics of interest, and certainly feel free to provide some suggestions. But certainly Australia has been a real leader in developing case mix funding models. Before we begin, I just wanted to acknowledge that the Institute, on behalf of the Institute of Health Economics, that we're located on Treaty 6 territory, the traditional and ancestral territory of the Cree, Dene, Saulteaux, Nakota Sioux, and the Blackfoot, and it's home to Métis settlements in the Métis Nation of Alberta, regions 2, 3, and 4. And we make this acknowledgement as an act of reconciliation and gratitude to those whose territory we reside on or are visiting, and whose histories, languages, and cultures continue to influence and enrich our community. I know a number of people are joining us from other parts and other territories that they live on. I really want to welcome two colleagues who are going to be presenting, and we'll get to the presentation right away. Jim Pierce, who's a principal with the Nous Group, and you've got the bios, but Jim, importantly to this presentation, led the introduction of casemix in New South Wales as head of the Department of Health's funding branch at that time, and has a long history in development of funding models. And Denitsa Mazevska had contacted Denitsa because she is on her way actually to Quebec City. She's president of the Patient Classification Systems International, which is meeting in Quebec September 9th to 12th. And while she was on the continent and actually close in the time zone, thought it was really a great opportunity. But she has a long history of dealing with the Patient Classification Systems International and systems in Australia, and was director of the Performance Analysis and Reporting branch at the New South Wales Health Department. They have a wealth of knowledge to share on the foundational elements of case mix funding and looking at Australia's experiences and lessons learned. We'll be following up, providing the presentation to everybody, along with some other links of ongoing activities we hope to do educationally. You are muted and I can't see you, so you'll be in a listening mode, but please use the Q&A function. And once and that's the one we'll be using to hopefully be able to get to questions at the end. But I think this is a very important policy development, and particularly in the province of Alberta where I live. But I will pass over to Jim and Denitsa to be able to provide I think a fantastic presentation providing an overview of case mix funding models in Australia and providing some insights. So Jim and Denitsa, over to you.
So as I said, we're going to explore some of the rationale for these reforms that were introduced in 2011 Australia-wide, and then describe how they've been implemented, particularly focusing on the lessons that have come out about some of the foundations that are required for these systems. And then we'll make some assessment of the progress that's been made and what are some of the gaps and future directions. So Australia moved to, over a period of time, to a universal health insurance arrangement. It was really only in the 1980s that was achieved. And what that meant was that all Australians were, from that time, covered by insurance arrangements for both medical care, hospital care, and pharmaceuticals. But whilst we implemented those those changes across Australia, we still have a very significant voluntary private health insurance system. And about 55% of the population still continue to have private health insurance, partly motivated by tax incentives and subsidies of the health insurance industry. And the private health insurance is one of the sources of supporting for the private hospitals. Now, in my talk, I'm going to talk more about the public hospital system. Now, Australia is a federal system with national government. I refer to that as our Commonwealth government. And then we have state and territory governments. And both levels of government are involved in both financing and managing healthcare services. So the Commonwealth government contributes around 40% of the overall health expenditures across Australia. These contributions are made through some major benefit programs, such as the Medical Benefits Scheme, which covers general practice and specialist care, and some elements of allied health and nursing care. There's also a national pharmaceutical scheme and a range of other schemes. It also provides grants for a range of purposes, including for primary care, First Nations health services, and mental health services. But a big role that the Commonwealth plays is grants to the state health services for public hospital care and a range of public health programs. Now, those grants were originally sort of set up to replace revenue that states and public and the hospitals that they managed gathered from charging patients for treatment within those hospitals. As I mentioned, the Commonwealth also plays a role in private health insurance through both tax incentives and subsidies. Now, the states and territories manage the public hospital system and a range of other community services. I'll just flick back, including some primary care services that fill in some of the gaps, particularly in remote and rural Australia, where the benefit programs for general practice are generally very thin and don't operate very effectively. And the states and territories are also very much involved in various public health programs. So this is a little map of Australia, just to give a sense of the differences between the states and territories. And you can observe that some, like in Canada, cover some very wide geographical areas, including very remote communities. And the populations of these states and territories vary widely, from around 8.5 million in New South Wales through to just 262,000 people in the Northern Territory. So this actually creates some of the challenges that there are in terms of managing systems like an activity-based funding system, particularly for the small states and territories. Now, before the reforms that I'm going to talk about were implemented in 2011, there had been a lot of activity occurring within developing casemix systems in Australia. This started, this involved sort of taking lessons from international settings. And I think Australia was one of the earlier countries that actually took casemix, in particular DRGs, quite seriously and began to utilise it. Now, next week, as John mentioned, we're having a conference in Quebec City, and that's going to be devoted to patient classification systems such as DRGs. And this conference brings together people across the world who are involved in implementation. So in Australia, as I mentioned, there was the adoption of the creation of a national program in the 1980s. But what really pushed things along was the implementation of casemix funding at a state level in the early 1990s. And but by 2010, there were a number of sort of limitations, I suppose, in terms of how things have progressed in implementing casemix approaches. States have progressed in their use at very different levels of pace. There was inconsistent approaches to casemix, sometimes some quite arbitrary funding rules, sometimes changes in the policies over time, over short periods of time. And also there was ongoing evidence of efficiency variation between hospitals across different systems. So at that time, the relationships between the Commonwealth and state governments were relatively acrimonious, and a core contention was that the Commonwealth government contribution to public hospital funding through the grants that I described before had dropped below what was the original or historical at the commencement of the Medicare universal system. At that time, it was approximately 45 to 50% of overall hospital costs. By 2011, it had dropped significantly to around 40% or a bit. And the figures I'm showing here are what the current sort of share of responsibility territory are for public hospital services. So currently, the Commonwealth share is sitting at around 37%, so it hasn't really increased substantially. State and governments contribute around 58% and private sources a further 5%. Now, the Commonwealth contribution is through three special purposes. These have been historically renegotiated. Before 2011, the grants were allocated to a population base with a whole range of.
Yeah, Jim, you faded a bit again too. You were really good, and then it just faded in terms of hearing you.
I hope I'll try to keep my
Yeah,
voice
that's
up.
good. Yeah.
Yeah. Okay. So, as a result of negotiations, an agreement, a national health reform agreement, was entered into in 2011. And this agreement had a very broad range of reforms included under it. But I'm going to just focus on those that relate specifically to ABF. So and these core elements around ABF are things that I'm just going to highlight. One of the first things was an agreement to move to a more consistent way in which public hospitals were organised. And this involved the establishment of what was called local hospital networks, or LHN. There was also a commitment to move towards activity-based funding. And that meant that funding allocations would be based on a national efficient price. And in fact, the states and Commonwealth governments would contribute to funding through a joint pool that was created through both Commonwealth and state funding, and then allocated to the LHNs on a national efficient price basis. Another commitment was that the Commonwealth would contribute to growth in activity at 45% of the national efficient price. Additionally, there were a couple of bodies that were set up to help govern the system and manage the system. The first was the Independent Hospital Pricing Authority, which has now become the Independent Health and Aged Care Pricing Authority, as its roles have been extended subsequently to aged care. Now, IHACPA, as we refer to it, provides annual advice on pricing of public hospital services, including taking into account safety and quality issues. It develops the advice on the national efficient price and also the weightings, price weights that go along with those national efficient price. So these are weights for, in the case of acute care, DRGs, with a set of additional adjustments for various factors. The price weights that we have in the Australian system are now referred to the National Weighted Activity Units, or NWAUs. IHACPA also provides advice on some block funding components, including the a national efficient cost, which is used for funding of small hospitals and other block funded services. Another body set up under these reforms was a National Hospital Funding Body and administrator, and this manages the flow of funds from the Commonwealth to the states, the state contributions, and the flow of those funds through to the local hospital networks. It has roles in terms of ensuring transparency and auditing and validating activity data. Under the reform, states and territories' roles were also specified, including that they were essentially the managers of the, and they do still control a range of factors that are included in the funding arrangement, some of which are not terribly well transparent. So they manage, for example, transition grants, target levels of activities that are set for LHNs, and the rules for adjusting contributions when activity is above or below targets. This slide just gives a bit of an overview of some of the funding flows that occurred in the 2023-24 financial year under these arrangements. And you can see both state and territory and Commonwealth funding going into two separate pools. The first pool, the National Health Funding Pool, is what's allocated on an activity-based funding basis. The second pool, called the State Managed Fund, deals with the block-funded components of funding.
Okay, so just swapping over, Denise is talking now. What we want to take you through now are some of the areas under which activity-based funding is organised in Australia and draw some lessons from those. So we'll go through each of these 5 areas. With data foundations, we've split this up into data standards and also clinical coding because we believe that they're both very important. John, can I just check that you can hear me well?
Yeah, very good, thanks.
Okay, fantastic. Okay. So there was already a strong foundation of data systems pre-national ABF in Australia. And in particular, there was a project in the early 1990s to standardise a data set for admitted patient care. And following that, other standards were also developed. And with the establishment of a national ABF, there were additional data that were required that weren't in the national standards. A key example that I can think of is diagnosis for emergency department care, which wasn't consistently collected across all the states and territories. So therefore, these national best endeavours data sets, or NBEDs, were created. And then as standardisation has been achieved on some of the data elements for these NBEDs, they've been rolled into national minimum data sets, or NMDSs. So the key lessons out of this is that standardisation of data is very important and you need to have this in place. But if you don't have perfect data, don't wait until you do. So progress with what you have and fill in the gaps later. There are always long lead times that are needed for any new data, and any system should not underestimate this. Some of the data elements I've been working with in Australia, they literally take, 5-6 years, for example, to implement. because there's IT training and a whole lot of other things involved. And we're going to refer to independence quite a bit, but in this case, the independence was around the Australian Institute of Health and Welfare and its role in data standards. So that was very important and very helpful in the Australian system to have confidence in the data and comparability as well. So continuing on with data foundations, this slide is specifically about clinical coding. So in Australia, we have had a long history of clinical coders and a very well-organised health information management profession. We've also had our own Australian modification of the WHO International Classification of Diseases, so the ICD system, and we introduced this in 1998-99. Before that, we used the American ICD-9CM system. And at the same time of developing this ICD-10AM system, we also developed our own procedure classification. So this is the Australian Classification of Healthcare Interventions, or ACHI. And ACHI and ICD-10AM are actually a part of a suite of products that also include the Australian Coding Standards, or the ACS, which is also a very integral component of the clinical coding. And IHACPA has been responsible for these updates since 2011, and initially they were being updated on a 2-year basis, but as time has moved on, we have moved to a 3-year cycle in more recent years. In Australia, it's the states and territories that are responsible for clinical coding assurance, and often they do this through audits. So the lessons here is that you do need an organised and well-trained workforce. So we work with some countries internationally where that doesn't exist, and that's starting to be developed as part of the ABF implementation. But that is a very important underpinning to get good quality, reliable data. And coding quality is, of course, very important, and this can be achieved through that workforce, but also through standards and audits. And we're going to come back to this again and again, but having this independent body to manage and update coding systems and standards in this case has also been very helpful. And just a small note on updates, while they should reflect changes in clinical practice, they shouldn't be overly frequent. So having something that changes too often, for example, annually, is really self-defeating, I think, personally. And a 3-year cycle seems to work for Australia, but depending on the system, somewhere between, a 2-year and a 5-year cycle, would be optimal. And early planning is also needed for any changes. Okay, moving on to classifications. The 2011 National Health Reform Agreement that Jim mentioned specified a set of classifications as national standards for activity-based funding. And some of these, for example, ARDRGs, were already being used by that stage by the states and territories. But others were newly introduced. So a key one here was the urgency-related groups for emergency department care. And this was actually, these were developed as a research project from someone's PhD, and, all of a sudden they were picked up nationally. And there was a lot of work that needed to be done in the system to actually implement that classification. So those classifications that were listed in the NHRA covered all hospital activities. So, for example, for mental health, you can see in the table there was no classification or separate classification before 2011. And at that stage, admitted mental health was covered by ARDRGs and non-admitted mental health by the non-admitted classification, which was the Tier 2 classification. But later we developed a special mental health classification. And also we replaced the emergency department classification. So it's the Australian Emergency Care Classification, which actually Jim and I developed in a major project where we undertook very detailed costing on emergency department services to develop that. And non-admitted is still, we have a classification, but it's not optimal at all. It's a service level classification, and that's the next priority. So the lesson here is that classifications do need to be available for the full spectrum of the activity that you're funding. So in this case, it's hospital activity. And this is so that you can monitor what goes on in different areas with the introduction of ABF. So you have these perverse incentives sometimes in ABF where you're shifting the activity, and that can occur, for example, if admitted care is more lucrative, some activity which was non-admitted can all of a sudden become admitted activity. I mean, in Australia, we have the concept of same-day admission, so, that's a very likely scenario. So you do need those activity classifications to be able to monitor what goes on in those different areas. And similar with data, the system doesn't need to be perfect to start off with. Classifications can be refined or replaced over time, and they should be in any case to keep pace with changes in clinical practice. And again, the independence factor in terms of refining, the classifications, so we know that, what has been updated or reflected is fair and it's a good representation of what the different stakeholders believe, should be represented. And the other point that we made here, and it probably goes back to, some of the data stuff, once you start introducing a classification for payment, the system starts to pay attention to the underlying data. So this, diagnosis in emergency department was a key example for us, but really clinical coding, as well. Okay, so with costing, we also had existing standards and a robust voluntary hospital cost data collection before national ABF implementation in Australia. So this is the NHCDC. And while it is voluntary, it actually has a remarkably high participation rate. So more than 90% of admitted patient activity is covered within that collection. But noting also that the NHCDC also includes patient-level costing of other service streams like emergency and non-admitted, etc., not just admitted care, but it has an extremely high coverage. So the lessons here are that, as with data specifications and clinical coding, standards are very important for costing, as are these processes for assuring the quality of the data. And with that, similar to some of the other points that I made, you can't fix everything at once. So you need to identify what the priorities are and work on those one at a time, or depending on how big, those issues are. But work on one thing, get that done, and then prioritise, something else. We found in Australia that standardised costing software and training in that software has been important at the state and territory level. So this is to achieve good quality costing. So just having everybody using the same system and getting familiar with that system has been quite helpful. Also, what's been helpful are benchmarking systems or portals. So they help services and clinicians using the data to understand how they can compare to others, and also to prioritise areas where they've got areas of focus for efficiency. And there's a few more points there about, the development of the weights, so using that cost data, but the main point is that representative samples of patient-level costing might be sufficient for generating the price weight. So you don't need 100% of, we've got 90%, but you don't even need, 90% as long as it's a representative sample that you're getting to develop those weights. In terms of pricing, in Australia, we have a high level of transparency in pricing, and this is through a series of advisory committees that HACPA has established, and they provide advice on various aspects of pricing. There's also a publicly published pricing framework each year that sets out the rationale for the pricing decisions and the priorities that are tackled in each round. And so this framework is initially published in draft, and comments are invited from any person or organisation wishing to provide them. So there's a public consultation process, and there's a window of opportunity for people or organisations to put in submissions to make changes. in Australia, Jim mentioned the national efficient price, so it applies across all settings, and these price weights, the NWOWs, are harmonised, and what that means is they're relative to one another across the different settings. And the pricing also includes incentives for quality and safety, so sentinel events, of course, in there, but also hospital-acquired complications and readmissions as well. The lessons out of this are transparency, that's very important, and it also includes principles to guide that pricing and transparency around those principles. Engagement is very important, so everyone who the pricing affects has an opportunity to provide their views and or evidence towards any changes that they want to put forward. And the ABF can have perverse incentives. For example, patients may be discharged quicker and sicker, which is the term that they coined in the 1980s in the US when casemix was introduced. So having incentives built in early to counteract these, like the hospital-acquired complications and readmissions, is very important. So here we're showing the NEP and the average cost per NWOW across time. And basically what we're trying to show with these charts is that as a result of the national ABF, the price has actually remained fairly stable over time. So the upturn that you see in that graphic on the right, I know you can't see that in very detail, but that's the years at the bottom and the level of the price on the y-axis, but that upturn at the end is due to COVID-19, which wasn't isolated to Australia. But you can see that that line is kind of remaining fairly stable over time. So ABF did have this effect. And similarly, the chart on the left, which is to do with changes in the cost per NWOW, reduced at the time of ABF implementation, and they also remained low, but there's that upturn, of course, with the pandemic. And this is my last area, so just bear with me for one more before we sort of do an overview of the whole system. But in terms of funding models, there are many aspects of how the funding model operates that are determined at a state level. So I think that that's very important to note. So it's not all set nationally. And while there is transparency very much so at the national level, there's less transparency about what happens at the state and territory level. The other thing to point out in the Australian situation is because of the way that the system is designed, the states have incentives to moderate the growth in activity. And the National Health Reform Agreement has provisions for hospital avoidance to be funded, but this is a really tricky thing. It's a bit challenging sometimes because ABF itself, as you know, incentivises activity, not reduced activity. So there's less incentive for services or states and territories to take this up. And it's not always easy to measure what has been avoided and, get paid for that as well. So it is a little bit tricky, and it's something that we're still working on. So in terms of lessons, ABF can be designed to moderate incentives for growth in activity. The targets that are set, which happens at a state level in Australia, should have strong links into planning and strategic directions for the system. And the properly designed ABF can incentivise other areas of demand, including these hospital avoidance or hospital alternatives, not just, acute admitted care. So they can include things like price equivalence for less costly modes of delivery, like virtual care, for example.
Okay, so we're actually coming close to time, so I will go through this pretty quickly, but we'd just like to offer our critical assessment of what have been some of the achievements and what are some of the limitations of activity-based funding in Australia. And we've already spoken about some of these achievements. I think the independence of advice has been a real strength of these.
Sorry, Jim, you do need to speak up a bit. You seem to fade wherever you're sitting.
Sorry, I'm not sure what's happening. But so the independent advice has been a great achievement. Transparency has been very important. There's a lot more understanding of the health system and some of the drivers within the health system. Efficiency is probably a plus. And the system has introduced some signals around quality of care built into price settings. I think there's a debate around the activity growth and cost containment. I think, as we discussed before, you can design it, and often states do design their incentives to manage growth to be appropriate at various levels. And there are provisions in the arrangements, and some have been demonstrated to work very well, but it's always been a bit of a struggle to get them in place to deal with hospital avoidance initiatives within the framework. Some of the limitations, again, there's been criticisms, I've talked about this, but we won't return to it, about that the system encourages activity growth. I think actually when you look at the activity growth that's occurred prior to the reforms and subsequent to the reforms, it's more or less on a similar trajectory. There are major issues about the interfaces between acute care and other components of care that are not being addressed in these current reforms. And there's an issue about whether the funding models are the solution to this or whether we need other policy instruments to deal with that. There's some limitations in classifications. There's work to be done there. But some of the areas that really we're working and trying to think through in Australia much more in the future is how we bring value and outcomes into the funding approach. I think I've just mentioned a couple of other things that I think are weaknesses that could be addressed in the future. There's been less attention to the issues of equity, particularly geographical equity under the system. And there are key modelling elements in the funding model that are less transparent. And I think they could be made more transparent, and in particular developed so that the smaller states and territories can utilise these models. A couple of areas that have been recommended in a recent review of the agreement have included areas like progressing models on bundled payment, blended funding models, the rewarding of high-value care and the penalising of low-value care, and incentives to accelerate changes in clinical practice and new technologies. I think there are different views we have about that, and we could discuss that a little bit further in our discussion. But one point I would try to make is that the funding model and payment system are only one of the policy instruments that we need in a system that's going to progress and address the sorts of issues that contemporary health systems are trying to address. And it's important that all the policy instruments are utilised together and harmonised. And sometimes there's, I think, an overemphasis on the payment system trying to deal with all of these issues. So we'll just go quickly, just our overall lessons. We've summarised these. Strong foundations matter, data quality and integrity are important, independence and transparency build credibility, change takes time, iterative improvement is a key thing to recognise, engagement is quite necessary, and funding models must balance a range of incentives. So we'll leave it at that and then go to questions. So thank you very much.
Well, thank you very much for the very comprehensive and great overview from you both of the development and the key lessons. We'll circulate these slides to everyone. We have had some questions and answers, and Denise and Jim, I might get to them right away because I think there's some really thoughtful ones. I'm going to bundle a couple from Tim Buckland, who's actually coordinating in the department, actually from the health department, trying to support a bunch of these initiatives. Is the IHA, the IHACPA, I don't know if how you pronounce it,
Oh.
yeah, okay. It's reporting to government. How does it function? Does it directly report to the Commonwealth government, and how independent is it? So I mean it's kind of governance. So comment on that. And just another quick question is, how does the AIHW enforce the receipt of data and data quality? Is there some linkage to payment, or is there some kind of mechanisms to kind of incentivize compliance in terms of reporting from the hospitals on some of the groups and their data? So the governance of the independent pricing authority, and then some incentives or that might be made around data collection.
So first of all, the IHACPA is actually a board that's established under national legislation, and the membership of that.
So you're fading again, Jim. I don't know I don't know why.
Very strange.
It's saying noise suppressed.
Yeah. Okay. Yeah.
We'll try and unset. But yeah, IHACPA is an independent board established under the national legislation. The membership of the board is agreed to by state and Commonwealth ministers together, and the board is actually the group that actually provides the advice. It's supported by the agency, which is a reasonably sized agency that undertakes the analysis of that. So there are sort of, because it's set up under federal legislation, there's sometimes criticisms that it operates to the advantage of the federal government, but in fact its membership is independent, and it's given a mandate to actually provide independent advice on these issues. So I think that's how that operates.
And it has a very high level of consultation with the states and territories. So there are formalised advisory committees that provide advice on all aspects of funding advice, and that includes, the cost data collections, the classifications, and, all the different components.
Right. And the second one was around the any kind of incentives to encourage the receipt of data and data quality.
Yeah, look, they don't exist at the national level. The AIHW has to work by agreement with the states and territories on the data collection specifications. The development of ABF has pushed some developments that have occurred, and IHACPA has had to work closely with the AIHW and the states and territories in working through how those specifications might be improved. The issue of data quality, it is sort of assessed when it's provided to the AIHW and IHACPA, but it's not necessarily, there's no enforcement of data quality. But IHACPA does have a provision that states and territories have to sign off on the quality of their coded data and their costing data, and give some attest that they've done what they can, and that includes a requirement to undertake audits, but that is all managed at the state level.
Right, and I think through its history and practices, it seems to have become a respected body that everybody kind of accepts is doing quality work, and that is useful. A couple of questions, and it came up around non-hospital based care. You did mention about the transition issues that occurred, and we may actually, for the group, trying to do some future funding model webinars around primary care or particularly continuing care models. But does the pricing authority look at similar activity models associated with either primary care or in particular continuing care or aged care?
Yeah.
Mm-hmm.
Yeah. So this, in a strict way, it hasn't done a huge amount of work as yet within the primary care setting. But when it was shifted from the Hospital Pricing Authority to the Health and Aged Care Pricing Authority, there's the capacity for it to provide advice on primary care services. There's a bit of arcane history about what was the boundary of what IPA at the time was required to provide advice on. And its advice was essentially around those services that were in scope, that were regarded as hospital services, and a lot of those include continuing care services and outpatient services and indeed some community-based services. But there are a set of services that are considered to be outside the scope of its remit at this stage in terms of the national funding arrangements. So there has been work on some of those models, but not necessarily to a great extent. And primary care really at this stage has been very much outside its work.
But aged care you mentioned in there as well. So that's something that IHACPA has picked up in the last couple of years, and it provides pricing advice on, it started off with residential aged care services, and we're just having a new model of support at home aged care that's being provided, that IHACPA has started to collect, stakeholder input and started to look at the pricing of that as well. So it does have that remit in relation to aged care, but it is still early days, particularly for the home-based care.
Oh, that's great. But they are building on a legacy of I think, foundational work of looking at data and cost data. Another question had come up, and I think you'd sort of answered it, but I think in remote and particularly rural areas, and I know in the activity-based funding formula, my understanding is that ones which serve a small population and therefore probably have to have a higher base funding overhead global budget because they can't actually have enough activity to reap the particular rewards off it. And you indicate that is developed by the states, or who develops that classification of what constitutes a small, to be small enough to receive that block funding? Who does that?
That's still within the remit of IHACPA. So they give advice on what they call the national efficient cost. And for small hospitals, they've got a specific model that applies for the smaller hospitals. It started off as a block funding hospital that sort of had several tiers of funding. It's now sort of more what you'd call a mixed or blended funded model where there's a block funding component, but there is an activity component for some of those hospitals, which is constant across the hospitals, but the level of the block funding changes according to the relative size of those rural hospitals.
Okay, and the foundational clues you've identified in terms of the quality and make sure to get the good data and quality case costing, etc. If you were advising a jurisdiction such as Alberta, who was going to be advancing down activity-based funding, what we call patient-focused funding, do you have suggestions in terms of areas to start that might be the most amenable to implementation based on the particular experience of because you can't boil the ocean, but what would be the most suitable places based on experience and lessons that you have?
Yeah. So I'm not sure if the person who's asking is looking for something sort of specific within these areas, but the foundational things are the activity data. So that includes, some standards around the data collections, that are required, and the clinical coding, and also the costing. So they're, the foundations on which everything else is built. So that's where I would start. But within those, there's obviously different priorities, and that depends on what your system is trying to achieve.
Yeah.
Yeah, I think, John, the question might also be about whether you would start with a particular set of activities, say,
Right.
Which I gather is what is happening in Alberta. It's proposed to start with particular procedures. They may be elective or emergency. I'm not sure. So I think that's it's not an unreasonable way to start is to pick some areas, but I would think that what our experience is, once you start funding one particular segment of activity on an activity basis, you then have to think about the management of some of the boundaries in terms of activity and the reporting of costs, and that can become quite problematic. So my advice in any system is to have a process to move reasonably quickly to a more comprehensive basis on the way you're doing activity-based funding. In particular, I think some of the boundaries between admitted care and non-admitted care, important that you don't create incentives around one part of the system that's going to disadvantage other parts of the system. But I do acknowledge that it's a tricky sort of question to look at, and I don't know whether you want to answer.
Well, I think having the mechanisms to monitor, like even if you're not funding the other parts to start off with, having a mechanism to monitor, what goes on in that other activity to see if there's any substitution, that is happening. So if you're funding elective cases and not emergency, then all of a sudden, everything becomes elective if the price is, lucrative enough. So just monitoring what is going on in the system is very important. And so you would prioritise those data elements, classifications, systems that would allow you to monitor what goes on in different parts that might be affected by what you're doing.
Right. And one quick question, then I have a one more final question. So just a quick response to the ABF. Does that, the ABF formula or whatever, is that different in Victoria than it is in Queensland? I mean, what variation is there across the different territories based on their particular context, or how much flexibility?
Yeah, this has sort of changed a little bit over time, but basically the national price and the weights and the technical elements are largely adopted on a national basis. But the states do have modifications that they sometimes introduce, and in particular in terms of how the local funding model might be designed and implemented, there are things that that states will potentially do differently. So, for example, what do you do when a service does not meet a target level of activity? Do you take all the money or all the funding away at an average price, or take it away at a marginal price, or make no change whatsoever?
Right.
Do you pay at the average price, or do you pay at a marginal price? So those sorts of things are very different, and the way targets are set, I think, is fairly opaque at the moment.
Right.
There's just some other examples at the margins, like in Queensland, for example, because the funding is targeted at a patient encounter, where there's input from another hospital towards that, the money goes to the hospital that has the patient with them. So Queensland has implemented this thing where they carve off some of that money, and they have a different component to fund the other hospital that provides the input to that care. For example, if there's some, stroke specialist, advice that's been provided.
Okay, and just one, there's just one last question from the audience, and then my final kind of question, so we'll just wrap up in the next couple of minutes. What the question was, how timely is your activity data, and what's that time lag? And I think it's down to 3 months, I thought, but I didn't know of when that was. But the other one is, I think I told you, what in the journey of Australia's journey to implement activity-based funding, you both are intimately involved, where you would go, oh my God, I would go back and change doing this. What was the thing we should have accelerated, that spent more time here or less time here, that kind of thing. But first, the timely data, and then what's one thing, if in your journey, that you would rear view mirror looking, you'd go back and kind of adjust. So the timely data, is it about 3 months, I think?
Yeah, it is 3 months. So they submit quarterly. So there's a 3-month time lag. Yeah.
Yeah.
Okay.
But just to add to that, at a state level, it's generally a little bit less than that, about 6 weeks or sometimes a month.
And that's the coding that holds that back.
Yeah.
So if you could go back in time with your particular journey, is there any kind of advice of where you go, oh, I wish we had maybe done this?
Yeah, I think from my perspective, and I'm going to be very selfish here and just think about myself, and I think there really could have been some movement towards sort of the national infrastructure a lot earlier. We did reflect that there were a lot of things happening, but at a national level, and it was very fortunate for Australia that they did happen. But I think there was a lot of energy put into designing and dealing with these things at a state level, and each state doing different things. And so the bigger states could manage that. The smaller states really struggled. I started my working life in the Northern Territory, and we had to negotiate the agreements around the sort of the funding agreements and things like that. There was a team of 1 or 0.02 of the person doing that. So the smaller states really struggle with that. But I think even the bigger states struggle with having a persistent, ongoing support for that. So I think setting up something like IHACPA earlier would have been a great advantage. The second thing that I think we've lost sight of is having an understanding about the future and how population needs are shaping our system, and having that developed in national or local models. So I do a lot of work in this sort of thing for the jurisdictions, but I think a national model about what's happening in the system and where it's travelling would be very helpful for states in thinking about how they fund their systems and what needs to change. And this needs to take into account all the things that are potentially happening around demographic change, health, morbidity change, and technology developments. So I think, again, if there was national work in that area, I think that would benefit all the states and territories as well as the Commonwealth.
Okay, thanks. So I think we have to, Denitza, unless you have one last kind of comment, I think we might thank you very much for the wealth of information you provided. I'll be sharing the link to the presentation as well as the presentation itself, and we'll be doing some ongoing ones to further explore some other areas. But virtually, people, on behalf of everyone who attended, thank you very much for the insightful content that you provided and the responsiveness. And good luck in the Quebec conference with the rest of your colleagues in the international community. Thank you very much.
Thank you.
Thank you. Thanks, John. Thanks, everyone.